Welcome back to Medicine Made Easy with me, Kavya Tendral. Now we are going to discuss the continuation of lymphatic filariasis. In this video, we will be discussing about the clinical features and management of lymphatic filariasis. If you are not subscribed to our channel, do subscribe for more interesting videos like this, and as well press the bell icon so that you will receive regular video updates. And the video link for part 1 is in the description. You can check it out. If you are not shared this video to your friends, please do share this video so that we will learn together. Coming to clinical features of lymphatic filariasis, we know basically lymphatic filariasis is going to be a manifestation per se by the nematode, or sometimes not the nematode per se, or something the part of the nematode, right? So when the nematode, the worm, adult worm itself is causing a pathology, that is, we'll see classified, or sometimes the worm is not actually causing the reaction, rather the antigen which is present in the wall or the worm which is going to initiate inflammation, that is called as occult filariasis. So it means in occult filariasis we don't see worms. It is basically the occult or cryptic filariasis, wherein the hypersensitivity reaction which is happening to the microflaria antigen, right? The worms also. So occult or cryptic filariasis means it is a hypersensitivity reaction. It is not because of the obstruction of lymphatic and so on, as like we see in lymphatic filariasis. So in lymphatic filariasis, when we are see sometimes the symptoms is not present, or the microflaria and the PBS is not present. PBS means peripheral blood smear. Sometimes the symptom may not be present, but microflaria can be seen. Symptom may be present, microflaria can be seen. When symptom is present and microflaria is seen, it means that is called clinically there is manifestation of lymphatic filariasis, and this time it is called as acute or chronic. Okay, let us discuss this in detail. Before that, we'll see what is asymptomatic amicrofilariemia. That means this is seen in the endemic areas. The person's is having the infection, but he doesn't have symptom. He doesn't have microflaria in the blood. It means you remember the time, no? He is in the pre-patent period, wherein the infectious larva which is present in the body, but it is not formed into the microflaria. Next, coming to symptom is not present, but microflaria is present. That means asymptomatic microflaria. That means this person is most common source of infection in the community. This is detected by night blood examination. Why night blood? Yes, because the nocturnal periodicity is the marker for lymphatic filariasis. That means only in the night from 10 a.m. to 2 a.m. only the microflaria will come into circulation. Only in that time only the mosquito is going to bite. And only by that act only the cycle is going to continue. So it means what? Microflaria is seen only in the night time, and so it is night blood examination. Next is symptom is present, microflaria is present. Yes, that is acute lymphatic filariasis. In acute lymphatic filariasis, what happens? This obstruction of the lymphatic worm, no? This adult nematode worm is going to obstruct the lymphatic vessels and glands. That is resulting in lymphangitis. The vessel is inflamed, lymphangitis. Lymphatic glands is involved, lymphadenitis. And because of the obstruction of the lymphatic gland and lymphatic vessel, that results in obstruction of the flow, that is resulting in lymphedema. In males, it is manifesting as epidermolysis. This is acute. But in chronic lymphatic filariasis, it is usually happening at 10 to 15 years later, the first attack. Why it is happening? Because of fibrosis and obstruction of the lymphatic vessels. Fibrotic obstruction of lymphatic vessels. Now, what are the two types? We said, right, there is Mucharera bankrupti causing lymphatic filariasis and Brigham causing lymphatic filariasis. If it is chronic, which has very specific manifestation, no? In chronic bankruptin filariasis and chronic Brigham filariasis. In chronic bankruptin filariasis, what happens? There is a lymphangitis, there is a lymphadenitis, and because of that there is a fibrosis which is happening in the vessels in the glands, that resulting in hydrocele, chyluria, and elephantiasis. So elephantiasis is not only because of lymphatic filariasis, it is also because of tumor, TB, radiation, and surgery. And this elephantiasis is can be seen in the upper limb, lower limb, genitals, and breast also. Now there is one thing to note, that is in silica also. Silica in iliac lymph gland will also cause this elephantiasis, but it is not seen in India, it is seen in Ethiopia. One important thing, in chronic bankruptin filariasis, there is hydrocele, chyluria, and elephantiasis. Remember hydrocele. This hydrocele, that is involvement of genitalia, is not present in Bruggen filariasis. Okay, this is very important. Again, one thing to note, other features will be present, but hydrocele, that is genital involvement, is not present in filariasis. Chronic Bruchian filariasis. Usually in chronic diseases of this lymphatic obstruction, the even chylurias will be decreased. Now, we are moving on to the management of acute dermatolymphangioadenitis. This acute dermatolymphangioadenitis management is given by WHO. That is first level care by WHO is recommendation given. See, what are the things is there can be uncomplicated ADLA or severe ADLA. ADLA means acute dermatolymphangioadenitis only. Okay, what is common for both in management is you should not use antimalarial medication. Point number one. Point number two, see, because of this en masse no, swelling of the legs, we can give paracetamol analgesics. First, we'll see severe ADLA. For severe ADLA, as commonly, no antimalarial medication and paracetamol should be given, and it is severe disease. No? So, we need to give penicillins. IV penicillin, let's make it simple. Penicillin, if there is penicillin, IV first initially give IV penicillin penicillin G 5 million units TDS, or you can give IM procaine penicillin 5 million units BD. Apart from that, after the conchum cure, no, then we need to give oral penicillin B. That is penicillin B, 750 milligram to 1 gram TDS. Minimum of 8 days treatment is needed for severe 8 days treatment. Or if there is penicillin allergy, you can give IV erythromycin 1 gram TDS until fever subsides. And then if fever subsides, then you can give oral erythromycin 1 gram TDS. If erythromycin is not there, you can use other antibiotics also. This is for severe ADLA. Simple. Penicillin, or if there's penicillin allergy, give other drugs. Initially IV or parenteral route, later there is oral. That's all. Don't give antiviral medication and paracetamol. And you have to give paracetamol for analgesics. Next, coming to uncomplicated ADLA. Uncomplicated ADLA, what happens? See here, this is a simple picture to just remember. First, see if there's any infection, cut or wound or abscess, first treat it. Next, advise the patient to prevent chronic lymphedema. Next is give antiseptic, no? This area should give a nice antiseptic cleaning. Then give antibiotic. Antibiotics, that is, you can give amoxicillin. The same again, penicillin or allergic to penicillin, give erythromycin. Amoxicillin 1.5 gram for minimum 8 days, 3 divided doses. Then you can give other oral penicillins also. Allergic to penicillin and give erythromycin. Simple. And ask the patient to follow after 2 days. Now, when he is going to home, what is the home management? Simple. In home management, ask the patient to elevate the limb, wash with cold water or cool the limb, increase the water. So these are the measures. Home management. And after that, after 2 days, you need to come to follow up. This is all about the management and clinical presentation of lymphatic filariasis. Hope you like this video. We'll meet in the next video. Till then, stay tuned. Bye bye.